Day 2 sessions revolve around inclusivity, resiliency, and the patient voice. And when we were first introduced to Randal, we were struck by his open, honest, and insightful story. So let's listen now as he speaks. Welcome, Randal.
Hi. Good morning.
Good morning.
Tanse, mio kasipiao, Randal Bell, nesatigasun, muniao sagahiginik, isigitu, itaskitan, Nihidao Nia Montreal Lake Nation Oche. Our nation is part of the Woodland Nihidao peoples Ote Saskatchewanak. Kuyask Nima Michihigok, Niwagamaganak, Tato Kisero. Hello and good morning. My name is Randal Bell. Montreal Lake Nation is the name of my territory, and I'm a Cree member of the Montreal Lake Cree Nation. Our nation is part of the Woodland Cree peoples over Saskatchewan, and my people make me proud each and every day. Now, Montreal Lake Cree Nation is one of the many signatories to Treaty 6, and I'd like to start out by acknowledging I'm on Treaty 6 territory today, and as a fellow Treaty 6 member, I'd like to thank the sovereign Indigenous nations of Alberta for welcoming me to their lands. I'd also like to acknowledge the proud sovereign Indigenous nations across Canada. The work we do affects all Indigenous Canadians, so the work we do must be done in the spirit of partnership and reconciliation. Let us start today by acknowledging the importance of that partnership and our firm commitment to reconciliation. So today we're going to be discussing a little bit we're going to be talking a little bit about trauma of Indigenous people, the role of Indigenous trauma, the role of adverse childhood experiences, and the role of social determinants of health. And we'll take a look at current state, Indigenous health, and the current state of addictions and mental health. And then we'll talk a bit about decolonizing health services. Next slide, please. So this is my daughter, Mackenzie. Her Cree name is Piwapan, which means sunrise. We look like twins here. So she's either got really good genetics or really bad ones. And by the end of this presentation, I'm sure you'll have formed an opinion one way or the other. But speaking of genetics, a growing number of studies have supported the idea that the effects of trauma can be passed on to subsequent generation through epigenetics. In 2013, researchers blew the scent of a cherry blossom through the cages of adult mice while zapping their feet with electricity. And after being zapped a few times, the mice associated the smell of the cherry blossom with pain. These traumatized male mice were bred with female mice. And when their pups smelled the scent of the cherry blossom, they became jumpy and nervous. More jumpy and nervous than pups whose fathers hadn't been traumatized by it. So maybe they learned this behavior from their parents. No, they were raised by unrelated mice who had never smelled the cherry blossom. The grandchildren of the traumatized mice also showed a heightened sensitivity to the cherry blossom scent. Neither of the generations showed sensitivity to any other smells, just cherry blossom, so the inheritance was specific to that scent. The second and third generation didn't fear the scent itself, but had a heightened sensitivity to it. So the findings supports the theory that the next generation doesn't always show the exact same trait their parents had. It's not the fear that's being passed down through the generations. It's the fear of the scent in one generation that leads to a sensitivity in the next. Now, another study went a step further. They extracted RNA molecules from the sperm of male mice who'd been traumatized, and they injected them into the embryos of mice whose parents had not been traumatized. The resulting pups, however, still showed that typical altered behavioral patterns of pups whose parents experienced trauma. There are still researchers who are skeptic about the epigenetic effects of trauma or the intergenerational effects of trauma. There's also the question of how it's passed on genetically, and that research continues. But many of us will recall the skepticism PTSD faced when it was first discovered. And let us think about how common that diagnosis is now in everyone from war veterans to traumatized ED nurses. And we'll come back to mice and cherry blossoms and whether or not the epigenetic effect is real. But I can tell you from my own personal and professional experience that the connection between historic trauma and intergenerational trauma is very real. Next slide, please. Neega-Wee's story. So Neega-Wee means my mother. This is my mother, Ivy. Her Cree name is Eagle Whistle Woman. Ivy's a Cree woman from Montreal Lake Cree Nation. Ivy suffered every kind of child abuse imaginable in the home she was raised in and suffered more of the same at Indian Residential School. As an adult, she suffered through years of domestic violence and struggled with PTSD, anxiety attacks, depression, and suicidal thoughts. And to cope with trauma and emotional pain, Ivy self-medicated with substance abuse for many years. Next slide, please. At 32, she left an abusive partner and went back to school with a grade 9 education. She finished her GED. Now a single mom with 3 hungry kids, she went on to university. And at 35, she found Indigenous culture, adopted a traditional Indigenous lifestyle, free from substance abuse. And after finishing her bachelor's degree in social work, she went on to finish her master's. She's been a successful self-employed mental health therapist now for over 20 years. She's traveled all over the world, achieving many of her dreams. She's literally 65, going on 16, and most days she drives me crazy. But my mother is a pillar of strength and resilience, and she's a huge inspiration to me. But to understand what happened to our family and many other Indigenous families, you need to first understand Indigenous trauma. Next slide, please. Historic trauma. Michelle Sotero at the University of Nevada has defined historic trauma in 3 stages. Initial phase, the dominant culture perpetuates mass trauma on a population in the form of colonialism, slavery, war, or genocide. In the second phase, the affected population shows physical and psychological symptoms in response to that trauma. In the final phase, the initial population passes these responses to trauma to subsequent generations who in turn display similar symptoms. Now, this speaks to the phases of historic trauma, but it also speaks to how it becomes intergenerational. This is the now famous painting by Kent Monkman called The Scream. Some find it sad, some find it offensive, but it is undeniably a visceral depiction of that exact moment people like my mother were ripped away from their family and siblings and homes and shipped off to residential school. Next slide, please. For over 120 years, Indigenous people were subjected to brutal enforcement of colonization and assimilation policies. In fact, it's well documented the South African government came to Alberta to observe these policies in practice and later used them as a model for apartheid. Over 150,000 Indigenous children were taken away from their families and placed in residential schools, like the one pictured here in Kamloops, BC. Thousands of residential school survivors would later recall incidents of physical, emotional, and sexual abuse, underage pregnancy, starvation, malnutrition, torture, and even murder. The mortality rates of these schools was between 40 and 60%. So by the numbers, the odds of dying in a residential school were higher than the odds of a soldier dying in World War II. The 60s scoop comes along and means another 20,000 Indigenous children are taken away. Many were shipped out in overseas adoption or placed in long-term foster care. And today we have the modern child welfare state, with 52% of all children in foster care being Indigenous. The Minister of Crown Indigenous Relations, the Honorable Dr. Carolyn Bennett, is quoted here as saying, "There are more Indigenous children in foster care today than there were at the height of residential schools. It's unacceptable and it's harmful." But to understand how all of this trauma affected people like my mother, we need to first appreciate the consequences of adverse childhood experiences. Next slide, please. For those unfamiliar with ACE's research, here's a 10-second crash course. Between 1995 and 1997, Dr. Vincent Felitti led a study of over 17,000 adults in California. These participants completed confidential surveys regarding their childhood experiences with physical abuse, emotional abuse, sexual abuse, physical neglect, emotional neglect, mental illness in the home, domestic violence, divorce, substance abuse, and the incarceration of a family member. The study demonstrated a strong connection between these childhood traumas and the poor health outcomes and social problems experienced later in life. Essentially, a child experiences a traumatic event or an adverse childhood experience, has disrupted or compromised neurological development in response. They struggled with social, emotional, and cognitive impairments. And they later cope with these difficulties through high-risk behaviors like drugs, alcohol, poor life decisions. This ultimately leads to disease, disability, or social problems, and ultimately an early death. The presence of high ACE scores and exposure to toxic stress in childhood is now commonly associated with higher rates of obesity, cancer, diabetes, COPD, higher rates of addiction and mental health issues, incarceration, and homelessness, and of course, early death. In fact, in Alberta, the life expectancy of an Indigenous person is 14 years shorter than a non-Indigenous person. But we'll get into all that later. Next slide, please. But understanding the Indigenous plight goes beyond learning about residential schools and adverse childhood experiences. It's also about understanding the cycles of trauma that they started and its effect on the Indigenous health. My mother had stopped substance abuse, left an abusive situation, went back to school, found her spirituality and her inner strength, but by then the damage was done. Like my mother before us, all three of us would score or would likely score 10 out of 10 on the ACEs survey. We grew up in an extremely dysfunctional household with an extremely abusive stepfather. Substance abuse and domestic violence were commonplace. We suffered many forms of child abuse and neglect. It was an unpredictably violent place, devoid of safety, structure, or stability. And most days were characterized by extreme poverty and food insecurity. Next slide, please. And my mother had the exact same childhood that her siblings had. And so the story of our extended family isn't much different than our own. 5 of my cousins are my age and they went to residential school. At least 20 of my cousins have been in foster care and or had their children in foster care. 3 of my cousins were murdered before they were 25. 2 of my cousins had mothers who were missing and murdered Indigenous women. 1 of my nephews recently died in a fentanyl overdose. 5 others survived fentanyl overdoses. All of these people have or had children who were growing up without a parent at the time. Next slide, please. The AHS Indigenous Patient Journey Projects, the IPJ projects. From 2017, a brilliant young man at AHS, well, he was young. Anyways, he led these projects that looked at what was working and what was not working and what was missing in addiction and mental health services delivered to Indigenous people. In IPJ1, we looked at 100 Indigenous high-need service users. These were predominantly homeless people with multiple episodes of care and addiction and mental health. And to understand the depth and complexity of their needs, we looked at the adverse childhood experiences and the lifetime trauma exposure. Now, the inner rings of these graphs represent their childhood, the middle ring, their teenage years, and the outer ring, their adulthood. As you can see, the level of trauma exposure in most categories increases with age, often well into adulthood. And we thought this was as bad as it can get. Sadly, we were very much mistaken. When we looked at 100 Indigenous people in Alberta correctional centers, we saw a picture of trauma that was much, much worse. The levels of trauma exposure were more than double the high-need service users in some categories. 98% indicating they had substance abuse problem. 95% indicated they suffered from anxiety, depression, suicidal ideation, panic attacks, PTSD, insomnia. Of the 200 people we interviewed, 41% were residential school survivors. 75% had a parent or parents who attended residential school. It's no coincidence. Many were survivors of the 60 scoops themselves or had lived in multiple foster homes as children. Many recalled the loss or disappearance of a significant female figure in their lives, missing, murdered Indigenous women. All of these men and women we interviewed have or had children who were at the time growing up without a parent. Next slide, please. So we know ACE scores increase the prevalence of high-risk behavior, substance abuse, smoking, DUI, overdose, these kinds of things. And we know that more ACE exposure pushes the risk of chronic health conditions even higher. So it's all about trauma? No, it's not all about trauma. In most cases, trauma started the fire in Indigenous health, but it's social determinants of health that keep that fire burning. Next slide, please. For those unfamiliar with social determinants of health, here's a crash course. The Center for Disease Control and Prevention defines social determinants of health as the conditions in the place where people live, learn, work, and play, and affect a wide range of health and quality of life risks and outcomes. In most cases, we're talking about food security, income, education, employment, housing, healthcare, and social context. And when we have good determinants of health, we have lower health risks and better health outcomes. And when we have social determinants of health, we have bad health outcomes. Simple. So 25 years ago, the Royal Commission on Aboriginal People raised the alarm on the social determinants of health and the poor Indigenous health outcomes. So let's see if things changed. Next slide, please. From 2008 to 2010, 54% of adults age 18 and over living in Indigenous communities lived in a household that experienced moderate or severe food insecurity in the previous 12 months. In 2015, Indigenous people in Indigenous communities that were age 15 and over had a median income of just $16,000. This is approximately half the median income of non-Indigenous Canadians at $34,000. Poverty is a barrier to health services, and putting food on the table for your kids is almost going to take priority over seeing the doctor. Next slide, please. Poor education and training opportunities affect Indigenous health. Limited access to the job market usually means a struggle with income security, which means poverty. Again, day-to-day survival takes precedent over health needs. In 2016, 57% of First Nations adults in age 25 to 64 in Indigenous communities had completed high school or post-secondary education. This was lower than the figure of non-Indigenous Canadians for the same group at 89%. In 2016, the unemployment rate among people aged 25 to 64 living in Indigenous communities was 22%. This is 3.5 times higher than the total population of Canada, which was only 6.4%. Next slide, please. Safe and adequate housing affects Indigenous health. In 2016, 44% of people in Indigenous communities lived in homes requiring major repairs, compared to only 6% of non-Indigenous Canadians. Poor air quality and black mold contribute to high rates of respiratory disease, asthma, COPD. In 2016, 36% of people in Indigenous communities lived in crowded homes, compared to only 8% of non-Indigenous Canadians. Overcrowding contributing to an alarming rate of high infectious diseases in Indigenous communities. And with this in mind, we really begin to understand why COVID-19 is so dangerous to Indigenous communities. According to the federal government, there are now more than 100 drinking water advisories in place, still in place for First Nations across Canada at any given moment. It's no surprise then that the rate of waterborne diseases in Indigenous communities is 26 times higher than the national average. This is the chief of Little Saskatchewan Reserve in Manitoba. Health Canada official told him that the water was fine to drink, but a private lab told him not to bathe his dog in it. Next slide, please. The Heart and Stroke Foundation of Canada states that heart disease rates for Indigenous people are as much as 50% higher than non-Indigenous Canadians, and the death rate from stroke is twice as high. In 2018, the Indigenous rate of diabetes is almost 1.9 times higher than non-Indigenous Canadians, almost twice as high. In 2018, the Indigenous rate of tuberculosis is still 34 times higher than non-Indigenous. And Inuit populations is 293 times higher. Next slide, please. Indigenous people have shorter life expectancy. Indigenous male life expectancy is 8.9 years shorter than non-Indigenous males. Indigenous female life expectancy is 9.6 years shorter than non-Indigenous females. And as I said previously, Indigenous people in Alberta have a life expectancy that is 14 years shorter than non-Indigenous Albertans. This is Harlan Labocan. And on the morning of November 13th, 2020, he began vomiting. His father had no phone, so he couldn't call him up for medical advice. The community health center wasn't open yet, and when it did, there wasn't a physician available that day. Upon admission, the nurses tried to resuscitate him, but tragically, 6-year-old Harlan passed away. Many Indigenous communities are located in rural and remote communities, so access to a doctor or a mental health clinician can be weekly or bi-weekly. This means Indigenous children, Indigenous people, Indigenous patients with chronic health conditions are particularly vulnerable in the event of medical emergencies. These risks are often compounded by challenges like not having access to childcare, to transportation, to a telephone or internet. As recent as 2018, the Indigenous infant mortality rate was twice as high as that of non-Indigenous Canadians. Next slide, please. And we'll take a look at addiction and mental health. The rate of mental health hospitalization is 3 times higher than non-Indigenous. The rate of hospitalization for intentional self-harm is 7 times higher than non-Indigenous. The rate of completed suicides among young Indigenous adults It's 5 to 7 times higher than young non-Indigenous adults. There are Inuit communities where the rate of suicide is 10 times higher than the national average. In Alberta, there's an Indigenous community of Musqueam had 14 suicides in 2 months. In 2015, it was estimated they had 70 suicides in a 4-month period. Now, this is a community of just 17,000 people. You have to ask yourself if it would be national news if there were 70 suicides in your community in a 4-month period. So right now in Alberta, the rate of Indigenous opioid deaths is 7 times higher than non-Indigenous. Now, some people are reluctant to call Indigenous health a national crisis or a violation of basic human rights. But I don't know how anybody can see a group of people living 10 to 14 years less than the rest of the population and regard it as anything but. So how do we move forward as health services? How do we move beyond the Indigenous health crisis? Well, the first thing we need to do as health services is acknowledge and remove the biggest and oldest systemic barrier to healthcare there is. What barrier is that, you might ask? Well, next slide, please. Well, we only need to look at newspaper headlines to answer that question. Brian Sinclair died in the Manitoba Emergency Department. He's a double amputee in a wheelchair who was presumed intoxicated and told to go away. He died of sepsis in the emergency department. And by the time he was discovered deceased 34 hours later, rigor mortis had set in. This is an emergency room in BC that was playing Price is Right, placing bets on the blood alcohol level of Indigenous patients. A woman almost died when she was presumed intoxicated, but was actually severely dehydrated. There's an article about AHS staff in Alberta being fired for racial slurs directed at leaders in an Indigenous community. Of course, the Joyce Echaquan death in Quebec, who filmed nursing staff saying horribly racist things to her as she died. And then another article, a few months after Joyce's death, 2 more nurses were fired after Jocelyn Ottawa went to a clinic for a wound dressing on her foot. The nurses humiliated her, saying they preferred to call her Joyce. They demanded Jocelyn sing songs for them in her native language. She then realized they had taken her phone away and were withholding it for the duration of her employment. These are stories that point to a national problem of systemic racism and discrimination in healthcare. In fact, Federal Health Minister Patty Hajdu attended a public forum following the death of Joyce Echaquan and later said, "Sadly, this is not shocking to me. Racism is not an accident. The system is not broken. It was created this way. And the people in the system are incentivized to stay the same." Next slide, please. Well, that's just mainstream media, right? Trying to sell newspapers? Well, numerous independent investigation and commission reports have confirmed it in the past. TRC report comes out in 2015, outlining numerous systemic Indigenous health inequities. First People's Second-Class Treatment report in 2015 by the Wellesley Institute. The Out of Sight report in 2017 that examined the death of Brian Sinclair. Key Health Inequities in Canada, a national portrait, is released by the Public Health Agency of Canada, which said if there were no inequalities between people living in areas with low and high concentration of Indigenous groups, there would be a life expectancy increase between 9% and 17%. Think about that for a second. If the Indigenous people in your community did not face health inequities, the life expectancy in your community would rise from 9 to 12%. In Plain Sight comes out in 2020. Mary Ellen Turpel-Lafon's report that surveyed 9,000 Indigenous people, 84% of whom indicated they experienced racism in healthcare. But this is all fairly recent discovery, right? No. The RCAP report came out in 1996. The final report was 5 volumes. That's 3,347 pages of documented Indigenous discrimination in Canada. And in 2016, 20 years after its release, a 72-year-old Paul Chartrand, one of the original commissioners, is quoted as saying, "There's a powerful lesson here, just to say, I don't think it's changed much." Now, these are reports that report to a national problem of systemic racism and discrimination in healthcare. And systemic racism and discrimination contribute to a lack of trust, makes patients feel unsafe and afraid to seek health services. Unconscious bias can be devastating and having fatal effects on clinical assessment, diagnosis, and treatment. Absence of trauma-informed care can also be a barrier to service access. So where do we go from here? Next slide, please. Health professionals need to understand that the health inequities experienced by Indigenous people represent the embodiment of structural and systemic disadvantages that were installed through colonization. And colonization was designed to displace and disconnect Indigenous people from their communities, their families, and their culture. They need to understand that the poor Indigenous health outcomes are a direct result of colonialism. So to reverse these health inequities, we need to decolonize health services. And there can be no decolonizing of health services without the implementation of TRC's health calls to action. So for clarity's sake, let's take a look at them. TRC talked about implementing the treaty right to healthcare. So First Nations, Métis, and Inuit have constitutionally entrenched rights to healthcare. And while Treaty 6 was the only treaty that contained the medicine chest clause, there's evidence to suggest many other treaties held oral agreements for the same provisions. Legal scholars are interpreting this, the medical chest clause, to mean access to free medicine and healthcare in modern times. Talked about establishing goals. Okay, a measurable action plan with KPIs. Makes sense. Talked about recognizing distinct needs. All Indigenous people have distinct needs. Cree, Blackfoot, Dene, Inuit, and Métis, on reserve, off reserve, all different and all distinct. And they need to have they need to be treated accordingly. Funding for healing centers. Sustainable funding for healing centers to address the legacy of residential schools. There are 12,000 residential school survivors in Alberta right now. They should have access to Indigenous healing centers that understand their trauma and pain. We could talked about recognizing Indigenous healing practices. Yes, health services should facilitate access to Indigenous traditional healing practices upon request. Talked about increasing Indigenous health professionals. Indigenous trust in healthcare is broken, and it can be rebuilt with the help of Indigenous health professionals. Talked about medical and nursing school curriculum. Absolutely critical. I did a presentation to about 50 psychiatry residents at the Alberta Hospital. Some were from Alberta, some were from different countries, but only about 3 of them knew what a residential school was. We're never going to improve Indigenous health outcomes until all health professionals are familiar with the traumatic history of Indigenous people and the unique needs they present as a result. Next slide, please. Empathy does not happen in a vacuum, and neither does racism or discrimination. Racism grows with a lack of understanding, while empathy grows with greater understanding. So how do we replace racism, discrimination with empathy? Well, we facilitate greater understanding. So we need to expand education and awareness of Indigenous health beyond cultural competency, understanding the current Indigenous health context, understanding the role of trauma in Indigenous health, understanding the role of Indigenous social determinants of health. We need to consider more trauma-informed care and the implementation of it. We need to look at comprehensive strategies to address racism and discrimination in healthcare. Consider understanding unconscious bias or the role of implicit bias. Excuse me. Next slide, please. Decolonizing health services means that health services need to change. And we need to challenge the belief that health services are static and embrace the reality that health services are constantly changing and may need to change faster, and so may we. We need to look at what Indigenous health data we collect so we get a clearer picture of the health needs and a clearer scope of the health problems. Harnessing the power of data ensures services will be designed for maximum benefit and impact. And we need to do so in Indigenous partnership with considerations for data ownership, control, access, and possession. Indigenous program development and research. There's this theme of discrediting Indigenous strength-based community-focused research. The literature reviews all say something like efficacy inconclusive, further research is needed, or results based on qualitative data, randomized control trial recommended. We need to move away from problematizing Indigenous peoples towards a focus on strengths, resiliency, and capacity building. We need to start looking, excuse me. Excuse me. We need to start looking at Indigenous program development and research in a way that's conducive to Indigenous health, culture, and identity. We need to think beyond reflexivity and challenge the very structure of Western-based research agendas in order to reframe and decolonize program development and research. The very term best practice is at odds with Indigenous culture and values. Best practice implies one approach is better than the other. Indigenous culture and wisdom would never keep score on something as important as health. All approaches to health and to helping those in need would be regarded as valuable or helpful to healing. Best practice is subjective. It's rooted in values, worldview, and perceptions, what we perceive as valuable. Best practice might recommend targeting those most vulnerable in the community, but those identified as most vulnerable in non-Indigenous community and those identified as most vulnerable in an Indigenous community might be two completely different populations with two entirely different needs. There's a recent Indigenous push to adopt the term wise practices in reference to programs or interventions that have proven helpful in Indigenous populations. And this really speaks to the fundamental ways valuable Indigenous research is being led with an Indigenous perspective. Next slide, please. Qualitative and quantitative data. We need to emphasize the value of qualitative data in Indigenous program development and research. In a culture that has so much of its identity rooted in oral tradition, it only makes sense to consider individual stories and experiences in program development and research. This should not be regarded as an evaluation deficit, but a strength. This also speaks to the value of user experience in program development and research. The IPJ projects taught us that Indigenous service users will only go to the services that deliver services in a way that works for them, even if it means not getting services at all. So it's imperative that we not only listen to service users, but we learn from them too. Building resilience through culture and spirituality. In the IPJ projects, we interviewed 200 Indigenous people who access addiction and mental health treatment multiple times. And we asked them, what factor influenced your sustained recovery the most? 22% said it was family and friends. 22% said it was a treatment program. But 35%, by far the biggest percentage, said finding culture and spirituality was what sustained their recovery the most. It only makes sense that we build on that strength in our program development and research. We need to utilize the two-eyed seeing approach, which is gaining increasing popularity in reconciliation efforts. Micmac elder Dr. Albert Marshall described the two-eyed seeing approach as learning to see with one eye with the strengths of Indigenous knowledges and ways of knowing, and from the other eye from the strengths of mainstream knowledges and ways of knowing, and to use both of these eyes together for the benefit of all. Utilizing the strengths of both Western approaches and the Indigenous approach for the betterment of all really describes reconciliation in action. And at the end of the day, two eyes are better than one, right? I promised my wife I wouldn't say that. Next slide, please. Parachute professionals. I use this term to describe the crisis response of certain health authorities, where they drop in a few health professionals for a month or two to stabilize a health crisis, then immediately withdraw them thereafter. We need to stop using parachute professionals and start supporting community-driven and community-controlled solutions. Communities have the solution because they are the solution, and they're there long after the parachute professionals have gone home. So they have to be the driving force of a health solution if the solution is to be sustainable in the long term. Temporary resources or supports are just band-aid solutions that delay the next crisis. So we need to look at community-based solutions, sustainable resources, and committed intergovernmental partnerships. Stopping cookie-cutter solutions. Government grants aimed at Indigenous populations can be prescriptive, paternal. Using cookie-cutter templates, they say, you need this program, write a grant proposal, and maybe we'll fund it for you. Needs should not be identified by external governments, but by the community struggling to meet them. Communities should be asked to identify what needs they have, and funding should support programs to meet those needs. Again, each community is unique with distinct needs. Shifting from crisis response to upstream prevention, there's very little support for Indigenous prevention programming. And so we need all levels of government and health authorities back at the table to look at prevention funding, Because as we say in health, prevention is always better than the cure. Next slide, please. And we talked about TRC and the health calls to action. These are all important to Indigenous health, but equally important, if not more important, is collectively acknowledging the inequities of Indigenous health as a human rights issue. The Royal Commission on Aboriginal People exposed all of these health inequities over 25 years ago. And we've done study after study, and they've all said the same thing. We need action beyond commission investigations and flowery political promises. And that only comes when we recognize Indigenous health inequity for the human rights violation that it has been, and a human rights violation that it continues to be. So what does it look like? Well, it's about committing to a response with the urgency we'd address any other human rights violation, with swift action and firm resolve. This means committing the resources and supports necessary to bring health services up to an equitable standard for Indigenous populations, increasing access and availability of health services so they're on par with what's afforded the rest of Canada. How do we do that? Indigenous health partnerships. Communication, collaboration, and coordination is needed between all levels of government, health services, and sovereign Indigenous nations themselves. This is a photo of our amazing Dr. Yu. Our illustrious CEO has been a fantastic champion of Indigenous health equity. And here she is signing a multilateral health MOU with HIROC Cree Nation that establishes a partnership in Indigenous healthcare. Next slide, please. The trauma of losing your culture, your language, your identity, the trauma of neglect, emotional, physical, and sexual abuse, coupled with the loss of parenting role models. Many Indigenous people were abused and neglected in residential school, and they went on to abuse and neglect their own children. Many had their children taken away from them, and the cycle of Indigenous trauma repeats itself. There are now more Indigenous people incarcerated in Canada than there were Black people at the height of South African apartheid. There are now more Indigenous children in foster care than were ever in care at the height of residential schools. Indigenous youth are one of the fastest growing segments of Canada's population, and they're also near top of the list of Canadians most likely to die. The need for active steps towards reconciliation isn't going away. It's growing exponentially. Next slide, please. Now, it's easy to hear all these heartbreaking realities and become overwhelmed with the scope of the problem, to lose hope. But I assure you there's much to be hopeful for. The Kamloops recovery and the recovery in Cowessess have shocked the country. There are now ground searches underway all across Canada, with 3 happening right here in Alberta. What we need to understand is the voices of these children have been heard, and they've woken a sleeping giant. From coast to coast and around the world, people are standing up and they're speaking out, and they're saying, every child matters. Many Canadians are seeing and hearing this truth for the first time, and so the journey to reconciliation can begin. And at AHS, we're well on our way. Next slide, please. At AHS, we adopted the Indigenous Roadmap to Wellness. This roadmap will guide AHS to develop the structures, processes, and organizational culture needed to respond to the unique needs of Indigenous people at the provincial, zone, and program level. We've developed and introduced the AHS position statement on racism. We completed Stand Up and Speak Out report, which had 36 recommendations to address racism and discrimination at AHS, and we've inserted those recommendations into crucial organizational strategies to ensure there is action, accountability, and measurable outcome. We've started a Stand Up and Speak Out anti-racism campaign across the organization. We've started the Diversity and Racial Equity Workforce Resource Group to support staff who are Indigenous, Black, and people of color. It has almost 700 members and counting. We've celebrated Indigenous Peoples Month with interactive education awareness activities for AHS staff. And on the National Day of Truth and Reconciliation, we put on a full day of programming, allowing us to come together to remember the lost children and the survivors, allowing us to reflect on our own commitments to truth and reconciliation. Next slide, please. Apologies for using this picture 3 times. It's one of only 3 pictures that remain from my traumatic and chaotic childhood. In the beginning of this presentation, I told you about my mother. the trauma she experienced as a child. Then I told you about the trauma her children experienced. So where are they now? Well, both my sisters have long histories of dysfunctional relationships and domestic violence. Both my sisters have been to addictions treatment more than once. Both my sisters have had their children taken away and placed in foster care at one time or another. We have all had or continue to have struggles with physical health, mental health, substance abuse, and the criminal justice system. Next slide, please. You drowned not by falling in a river, but by staying submerged in it. Escaping the trauma of our childhood has been difficult, and some of us remain submerged in it. But like my mother before me, I too found a way out. I followed her footsteps through university, and I went on to a career that has taken me around the world. And like my mother, I've achieved many of the dreams I once thought impossible. And on this journey, I've learned many things. I've learned that healing is a lifelong process. Some days are harder than others, but it gets easier over time. I've learned about the power of unconditional love and forgiveness. Once an angry and violent young man, I'm now a warm and loving father who's built a safe and happy, healthy home for his family. The Indigenous cycle of trauma may not stop with my sisters and their children, but it will certainly stop with me and mine. Next slide, please. Indigenous truth and reconciliation is not a cry for sympathy or pity. Indigenous truth and reconciliation is a plea for understanding. So please understand that you have an important role to play in Indigenous reconciliation. You can help others understand the role of Indigenous trauma and the importance of trauma-informed care. You can help others understand the role of social determinants of health. You can stand up and speak out against racism wherever and whenever you see it. You can look for opportunities to decolonize health services for Indigenous patients. You can help build Indigenous trust in healthcare so Indigenous people can get the help they need. I'll leave you with this final thought on traumatized mice and cherry blossoms. When the traumatized mice were systematically sprayed with the cherry blossom scent without the electric shock, they eventually stopped reacting to it. Their brains had rewired the response to the point their sperm no longer held the epigenetic signature of the trauma response. It's early days, but the study suggests once trauma is removed from the equation, traumatized brains can be reprogrammed, so we no longer live in fear and anxiety. Our DNA. As health services, we can help stop the cycles of Indigenous trauma from being passed on to the next generations. Maybe as health services, we can support the next generations with greater health equity. So we can all move towards reconciliation, not just as individuals and families, but as friends, neighbors, and communities. I hope you all enjoy this presentation. Thank you all for being here today. Thank you for listening. Egose, Nina Naskoman. Hi, hi.